management. Baby with a spina bifida needs to be positioned on their abdomen, and then the defect covered with sterile saline dressing. We want to protect that sac, that herniated spot from any pressure, especially if there's spinal cord in there, and then infection. Surgery is done as soon as possible. We're talking like in the first 12 to 18 hours after birth to try to reduce and fix this. Meningitis and hydrocephalus are common complications. So we're checking that head circumference with that hydrocephalus and looking for, Cushing's triad, that kind of thing. And meningitis, we're looking for fever and a few other things we'll talk about coming up. So measuring head frequently. Increased risk of latex allergy is found with this just because of how many medical things that need to go into taking care of somebody with a spina bifida issue. Okay, the next thing we're going to talk about is the cleft lip and cleft palate. These are the most common congenital malformation. May occur alone or together, meaning cleft lip, cleft palate, but it's often going to be seen together. It's a cosmetic and functional defect, so not only does it have a certain appearance about it, but it also doesn't function the way it's supposed to. If it goes up into the nasal structures, it is interfering with, the nasal structures, plus the ability to eat and everything like that and breathe. Etiology is going to be a genetic cause, an environmental cause, smoking, lack of folic acid in those beginning months, and then alcohol and other seizure medications can increase the incidence of cleft lip and cleft palate. So the cleft lip, this is a failure fusion of the lateral medial tissue to form on the upper lip. You can see in that picture here, severity can be unilateral, meaning one side, which is what we see here, or bilateral, which kind of goes up both nostrils, and then maybe a slight dimple to involving the entire nasal structure as well. This is repaired soon after birth. And then we look at, appearance and scar reduction. We want to keep this area clean as possible, so after feedings, we're going to rinse with sterile saline. Okay, cleft lip and palate, there you can see a picture. This is a bilateral complete, so it's going all the way up into the nares and it's on both sides. Okay, cleft palate, this is where the palate, the roof of the mouth, is not fused together, so there's going to be gap there. Can involve the soft palate, the hard palate, or both. And then this is usually going to have to be repaired in stages. It just depends on how severe the case is, what structures are involved. And then this is going to grow and change. So that's also why this is going to have to be repaired in stages. A multidisciplinary approach is going to be needed for a cleft palate because we're going to need speech therapists, occupational therapists, nutritionist, that kind of thing, that's going to help in making sure that this kiddo can get maximum calories and then learn how to kind of, adapt to this. All right, so here's a picture of what that cleft palate looks like, that roof of the mouth, the gap there. This would be a unilateral, and then it's complete, meaning it goes through all the soft palate and the hard palate. So the biggest problem with this is feeding. In order for a baby to eat, this is something they were born with. In order for them to eat, they need to be able to squish nipples flat, whether it's the bottle nipple or breastfeeding nipple. They need to squish it flat against the roof of their mouth in order to have good suction and drink. So right off the bat, they can't do that. So then, they're not getting adequate nutrition, or it's harder for them. It's more work for them to be able to do so, which is going to burn more calories as well when they need as many as they can get for growth and development. And then the other issue is, especially if it's involving the nasal structures, they're at more risk for aspirating, that milk is flowing to where it's not supposed to be and getting in their respiratory tract, and then we worry about infections and that kind of thing as well. So emotional reaction of parents, obviously this not only has a certain look about it, but then we're talking about multiple surgeries, lots of care, possible complications that can be serious, so it can be very traumatic for parents. And then I already talked about the risk for aspiration and respiratory distress as well. So they're prone to otitis media, so ear infections, because all those structures are kind of connected in there anyway. But then if you have this malformation, they're really connected and can really be impacted. And so we need to take measures in order to help prevent that otitis media from happening, from that milk being flowed into the ear, the middle ear area. They can have difficulty sucking, just like I had talked about, may need special shields on the nipple or even fed by a dropper. Needs to be fed in that upright position. That's going to help keep some of the milk out of the airway. Burping frequently because they're going to swallow more air with this. And then we never want to prop bottles anyway, especially with a cleft lip or palate situation. The procedure for feeding these babies is going to be ESSR. So using an enlarged nipple for baby to drink, it's going to be bigger and longer. Allow that suck reflex to, have them have that good suck, hear the swallow, and then allow them to rest. That's what we're going to have to do. It's a long process. It takes a lot of energy, but this is how we reduce infection and aspiration. Okay, post-op care for cleft lip or cleft palate. They're going to be prone to respiratory distress and hemorrhage. So lots of bleeding issues, and then bleeding right into the airway is also a big concern. So we're going to be monitoring vital signs and making sure that they're breathing okay, looking for those perfusion signs, capillary refill, those kinds of things. Arms need to be restrained after the procedure, so it's usually going to just make sure their elbows don't bend so they can't touch their face. We don't want them to touch that suture line at all. And then remember to release every 2 hours to allow extremities to move. A Logan bar or Logan bow, however you want to call it, is used for cleft lip repair. It's used to prevent pressure on that suture line. So you can see a picture there. It's just supposed to squish these areas together just a little bit. We don't want it to straighten out too much. Then putting pressure on the suture line and it possibly coming apart on us. And then baby needs to be positioned on their back so we don't put any pressure on that as well. Here I've got some pictures here. You can pause to take a look if you want to. Here's some repairs that have been done. And then here's some more pictures of repairs, kiddos, and then actor Joaquin Phoenix after having cleft lip repair. Okay, another thing that we're going to talk about is club foot. This is a congenital fixed postural deformity in which the foot is twisted out of shape or position. The heel is turned inward from midline of the leg. The sole of the foot is flexed at the ankle joint, and the Achilles tendon is shortened. So what does that look like? Here's what it looks like. So the Achilles tendon is shortened, pulling the heel upward. Okay, you can kind of see that here too. Heel upward, and the foot is flexed. How we know that this isn't like baby that was just in a really weird squish position and this is how they're delivered. Those babies' ankles will be moving freely. We can bend them from side to side. They're very flexible. These feet are going to be stuck this way. They will have very little movement to them. Okay, and then there's another picture of club feet. This is a bilateral involvement. Cause unknown can affect one or both feet. They need to be evaluated carefully. We want to make sure like this is club foot or not, or maybe just, baby was positioned really funny and squished up in the womb and, we can bend the ankle. So yeah, like I said, true club foot cannot be manipulated past its neutral position. Treatment initiated as soon as the infant is stable. So it's going to be in 3 stages. We're going to need to correct the ankles, maintenance of that correction, and then long-term follow-up. There's usually going to be some kind of a surgical repair, whether it's to elongate that Achilles tendon or maybe some other tendons need to be cut and that kind of thing. And then after that, we're going to have to wear one of these Dennis Brown splints, which is the splint with shoes, or even casts may need to be worn. And because of the rapid growth and development here, a plaster cast, if we're going to do this route, needs to be changed frequently, as every 3 to 7 days over a period of 10 weeks. So the idea is to keep those ankles in a normal position in order for those tendons and things to heal, so we don't have that club foot issue coming again. Surgery post-op, we're going to elevate the foot to help with swelling and pain, do neuro checks, and then cast care, keeping it dry and clean, and we're not going to put things in the cast. Okay, metatarsus adductus. This is another kind of like minor case of club foot. So this is where we have a non-rigid medial deviation of the midline or midfoot. This usually does not require surgical repair. This is just going to be a lot of physical therapy and, wearing a specific kind of shoes to help stretch out the bones and the tendons that are in there. Congenital dislocation of the hip. So this is where the acetabellum, which is the socket of the ball and socket joint of the hip, is usually not pronounced well. So here is a picture of a normal hip joint, and here's the one with the congenital dislocation. You see it, the socket joint's just not well formed there. Cause is going to be genetic, and then lax ligaments just won't hold that femur where it's supposed to be, which can be an underlying factor. 1 out of every 1,000 infants are born with a dislocated hip. So here's another picture of normal hip, nice ball and socket, and then here's the hip dysplasia where we don't have a good socket joint and it's allowed to move. And typically this is going to move upward and backwards, moving posterior to baby and upward. So what does that look like? Well, that is going to have the manifestations of shortening of the affected leg, abnormal skin creases in the thigh and extragluteal folds, shortening of the femur when knees and hips are flexed at right angles. So here's a picture, and you can see that there's extragluteal and thigh folds because the hip joint, that ball, is being pulled upward and posterior, shortening that leg. And then here's another picture of the knees bent at right angles, and you can see that the femur is actually shorter than the other leg because, again, that hip is pulled outward and upward and to the back. Okay, Ortolani and Barlow tests are screening that are done on babies and at well baby checks. So for the Barlow test, the knees are going to be flexed backwards and then from side to side, and then the Ortolani test, they're going to be flexing the knees outward into kind of like a frog position, and they're looking for clicking or extra movement that's felt inside the hip, or that it's like stopped on one side, that it's totally like unequal movement. And then diagnosis can be confirmed by x-rays. So here's that Ortolani where they're moving the hips apart from each other, the knees apart from each other. And then here's the Barlow where they're moving the knees upward, and then they may abduct as well with this one. Treatment, mild cases, we'll do double diapering. So we're gonna do 2 diapers, and it's going to keep the leg abducted outward so that those tendons can mature and hold that femur head in place. Others, we may do spica cast to maintain the leg in a frog-leg position. You guys can see that here, that there's a spica cast. And then the Pavlik harmonious, which is this thing and that thing, that can be worn as well. That needs to be worn for at least 23 hours a day and taken off just like for a bath or cleaning or something like that. It's not for like an hour at a time. It's just that it's allowed to get out for cleaning and that kind of thing, but then right back in it. Cash, you can see that there would be issues with diaper changes and that kind of thing. So lots of education on keeping diaper clean, dry, don't put things in the diaper, and then, or in the cast, and then, and changing often. And if the cast does get soiled, that the cast needs to be changed out. Surgery may be needed in order to fix this problem as well. So, think of those post-op elements as well, and then casting is common after that. I'm just checking my for casting, looking for rough edges. We do have like they call it moleskin that we can put on rough edges of the cast in order to help maintain skin integrity. Varying degrees of congenital hip dislocation. We have unstable, which is the head of the femur is located within the joint, that acetabellum, but it may be subluxated, just meaning it might be facing the wrong way. Subluxated is partially dislocated but positioned under the edge of acetabellum, but not well seated, so it's in there but partially out. And then dislocated is it's completely outside of the socket joint. Okay, I'm going to end this recording here, and we'll continue.